So it is truly an honor to welcome Dr. Ben Hoffman to Randall Children's Hospital Grand Rounds. I cannot tell you how excited I was last winter when the American Academy of Pediatrics announced that the incoming AAP president hailed from our very own state of Oregon, and even from just across the river at OHSU. In his welcome letter to the Academy, Dr. Hoffman wrote, "One thing that I love about pediatrics is that through all of this, heaped upon the lingering aftermath of a global pandemic, we remain pediatricians. We smile, we laugh, and we care for each other with the same kindness, excellence, and loving fervor with which we care for our patients. Yes, it is hard, but hard does not scare us. Bring it on. We are ready." And since I initially read those words, I have had the privilege of getting to know Dr. Hoffman at local Oregon Pediatric Society events and at the National AAP Advocacy Conference in April. And what struck me immediately in these interactions is that Dr. Hoffman is a leader who truly understands the moment that we are living in. He understands the stressors and the pressures that are affecting not only America's children and families, but also that are affecting the pediatric workforce that is struggling with burnout and being under-resourced to meet those needs. He is a true advocate for pediatricians and for children, and I look forward to hearing his inspiring message on pediatric advocacy today. Dr. Hoffman completed medical school at Harvard University and his pediatric residency at Seattle Children's Hospital. And he is currently a professor of pediatrics at Dornbecker Children's, where he is the vice chair for community health and advocacy, the director of the Oregon Center for Children and Youth with Special Health Care Needs, and the medical director of the Tom Sargent Safety Center. He's nationally recognized expert in child injury prevention and a leader in the field of community health and advocacy training. Dr. Hoffman, thank you so much for joining us today.
Thanks. It's such a thrill to be here. I've spent a lot of time at Randall working with the injury prevention folks, probably more time in the parking lots than anywhere else doing car seat installations during car seat technician training. But it's wonderful to see some familiar faces, a lot of faces that I don't know yet, and I look forward to getting to know you. And I'm really honored to have been invited today, and so I want to thank Wendy and the rest of the folks for having me. And maybe this won't work, which is fine. Maybe that's it. There we go. Now we got it going. All right. So we're going to talk about advocacy today, and advocacy in the context of our roles as child health professionals. And I specifically say child health professionals because I presume not everybody in this room is a pediatrician. We know that high quality child health care occurs in high functioning teams, ideally pediatrician led. And our community of providers and health professionals need to be able to work together to be effective. But what I also know is that really what we're going to talk about today is exactly why you chose to do what it is that you do. So I have nothing to disclose other than the title of this talk, because all we have is each other, is the only talk that I have ever stolen a title from off of a bathroom wall. This happened to be in a bar in Cleveland where my roommate from medical school lives. And I was giving a similar talk and I had what I thought was a good title, and I saw this, I'm like, no, I got to steal that. All right, so I want to start by bringing you back to your first social science class, whether it was in high school or college, and hopefully this doesn't cause PTSD in anybody, but Maslow's hierarchy of needs. And I want you to think of this in the context of the patients and the families and the community that you serve, in whatever role you have, whatever you do. What Maslow was trying to say here is that we have to be able to get from Monday to Tuesday, simple survival, before we can start to move on to the things that really make us human. And I will point out that the bottom two categories here, safety and physiological needs, are also required by turtles, right? There's nothing uniquely human about that. So think about the families that you serve. Think about the families that you've seen this week in the PICU, in the clinic, in the emergency department, wherever. Where are they on this hierarchy? Are they in a place where they have the capacity, the capability, the agency to dig into what actually makes us human around belongingness and love and need for self-esteem and esteem for others? And do they ever even have a chance? Like the kids you care for, do they have a chance to actually achieve full potential? I want you to think also about why you went into what you went into, and go back to you as you were finishing up your terminal training degree, whatever that was. And how did you think your life was going to go? What did you think it was going to look like? So I have one other thing to disclose. I'm a recovering residency program director. I ran the residency program at University of New Mexico for almost 9 years before I came here to Oregon. And I estimate I've read probably 8,000 personal statements. I know there's at least one person in this room I've read their personal statement, may have been more. But I can tell you every one of those 8,000 says essentially the same thing, right? I love kids. I love science. I want to do good things for kids. And that's why I want to be a pediatrician. And if you Google, what is pediatrics? Do an image search. And I did this. This is from 2 weeks ago. These are the images that show up. This is what I thought it was going to look like. This is what I thought I was going to do, because that's what, right? This is what the public sees. Is this what your life is like? Like you had that one day once, right? It was a good day. This is what people write about. I have never once read a personal statement where somebody said, I'm so excited about EPIC. There's probably one or two nerds, and apologies to you if you are one of those nerds, but this is killing us slowly. And I feel like the vision of pediatrics, the images that I see and feel are more like this. This is what I hear about when I go around and get to meet folks. This is what we hear about at the academy at the national level. This is what we hear about the Oregon Pediatric Society. This is not okay. It's not, because if we're not all right, we can't be all right for the kids and families and communities that we serve, that we committed to help. So many of you may remember Bill Frist, some of you may not. He is a former US Senator from Tennessee. He's also a cardiothoracic surgeon, and his family are the owners and founders of Healthcare Corporation of America, one of the largest health insurance companies in the world. And he said, America has the best of everything, so there's no reason we shouldn't have the best healthcare in the world. You guys see healthcare. Is this true? And we can argue we have the best of things. And yeah, I think it's probably true. There's no reason we shouldn't have the best healthcare, but we know differently, don't we? And we know there's proof of that. So this is data taken from the Organization of Economic Cooperation and Development, which is basically the 48 largest economies in the world. And this compares the US to the rest of the OECD countries, so our peer nations in terms of economic status. And it shows, as we all know, especially following the Olympics, that USA is #1. Although in this setting, it's in dying. We die at higher rates at every age from birth until 74 than our peer nations. And we have the best of everything. We're the richest nation that's ever existed in the history of the world. When I think about pediatrics and what it's really like, and I say this unabashedly, as you know, I am the president of our professional organization. Like, I love nothing more than being a pediatrician, other than being a father and a husband. What do we actually see? What do we think about when if somebody asked you what pediatrics is? This is I think the most appropriate quote I've ever seen. Paul Wise is a general pediatrician at Stanford. This is how we spend our days. Abraham Jacobi is the founder of the founder of pediatrics in the United States. So he was a German Jew who was imprisoned in Germany, and when he was released from jail, he emigrated to the U.S. as a pediatrician, ended up on the Lower East Side of New York City, and basically founded the practice of pediatrics in the United States. Amazing guy, wonderful stories. And he's famous for saying this, that it's not enough for us pediatricians to just work at the individual bedside or hospital, but in the future, we should be sitting on and controlling school boards and health departments and legislatures And we have the legitimate responsibility and right to be advisor to judge and jury and have a seat on the councils of the republic, because that's what the public has a right to demand. Is this what you do? So he said this in 1904. The Academy was founded in 1931. Where are we in terms of realizing his dream? Our Academy doesn't disagree with him in the policy statement on the role of pediatricians in communities. And this is not just primary care pediatrics. This is everybody who is a child health professional. That we need to be able to successfully merge our traditional clinical skills with public health population-based approaches to practice and advocacy. Basically the same thing that Jacoby said 100 years before. We know that seeing us is important, especially, and I say this as a general pediatrician, primary care, right, is crucial. My job is to make sure that Wendy and Christina never get to see my patients in the PICU. Right? I'd love to work you out of a job. It'd be great. But we know that what goes into actually making a person healthy is it's partly us, but to the greatest degree, not so much. That access to care, being able to see us, accounts for maybe 10 to 20%. In this estimate, it was 6%. And the rest of it are things some things that we really can't control, although even with genetics and what we know now about toxic stress and epigenetics, you can make an argument that those are modifiable. But the socioeconomic and the physical environment and the behaviors of the individual and those around them, especially for kids, make up the majority of what allows a person to be healthy. And we in this country spend $4.5 trillion on health, and we spend 90% of it on the part that has the smallest impact. And that just doesn't make sense. And what we get for that as a system, and I want to be very clear, this system exists for a reason, because we have allowed it to exist. And what we get for it is that we die at higher rates than everybody else until you hit 75. My parents are 81 and 82. They are finally reaping the benefits of the way that our system works. We see people on the other end. Our system is built to achieve this result. We've got to fix that. This is not okay. There is a tremendous gap between what the healthcare system values and what we are incentivized to do. Where we interact with patients and how we interact with patients and how we're paid and supported to do that. And I mean individuals, practices, institutions, states, and what it really means to work for the health of an individual, especially a child. There is this gaping chasm that exists between healthcare and health. And when I work in healthcare, it's very clear to me in an exam room, there's not a whole ton that I can do to really impact the health of a child, and certainly not their community. But I have a role in public health in this state in directing the maternal child health program for kids with special health needs. And when I work in the public health space, nobody there understands how healthcare works. We've got to figure out how to connect this, because when we dig into what it really means for kids, we currently rank 54th in the world for infant mortality as the richest country that's ever existed. Here are the OECD countries. I, interestingly, this year have had the opportunity to do essentially this presentation in both Japan and Iceland, the two places that have the lowest infant mortality, and then say, well, there we are. right between the Slovak Republic, Russia, and Chile, where you would expect the United States to be in terms of infant mortality, right? And we know that risk for infant mortality is not equally distributed across the communities for whom we care. And that Black and brown kids from minoritized and marginalized communities, bear a much higher burden. I don't have to tell anybody in this room about the absolute dumpster fire emergency around behavioral health. We now thrice, the Academy, in concert with the Academy of Child and Adolescent Psychiatry and the Children's Hospital Association, have issued declarations of a national emergency. And it is nothing short of that. Right? Again, I don't have to tell anybody in this room. I find this particularly impactful. It just sort of hammers it home. And I can't imagine, especially as an injury prevention nerd, ever getting to the point where I would say that guns are the single leading cause of death for kids in this country. It's been injury forever, right? But in 2020, the lines crossed. And we know that that risk is not equally distributed across the community, because if you're a Black male, you're 18 times more likely to be killed by a gun from someone else. And those rates are increasing. If you're American Indian, Alaska Native, the rates of suicide by gun are astronomically higher than any other part of the community. And I think a lot of this gets down to, again, structural things that we have either created or allowed to persist, one of which is poverty. And all of the things that create and perpetuate poverty at a structural level, including racism. I just got off a call with the executive committee for the AAP, and we were talking about our national meeting, which is going to be in Orlando. Turns out we will not be able to say structural racism or systemic racism at that meeting unless we're willing to go to jail. And I'm seriously debating about where I stand on that. So we're going to pass around a hat later for bail money for me, if you're willing to contribute. So we hear a lot about these things, and I want to dig into poverty, because I've positioned it as this thing that we have created or allowed to persist. And I love this quote from Mandela, who said that indeed poverty is not an accident, that it is something that we create, like slavery and apartheid. And if we do it, we can fix it. In order to fix it, to dig in on it, we have to understand it. So first and foremost, kids are the poorest population in this country. And it's not just because they don't work. I don't want to hear that. They live in poverty. This data is from 2010. I keep this slide just because it demonstrates this most effectively, but the numbers have changed a little bit, but the proportions have not changed in the 2020 census. You can see that in 2010, 22% of kids lived in poverty, and 10% of kids lived in deep poverty. And that the risk for poverty is greatest for the youngest kids. And I will explain in a second why I think that's particularly troubling. And this shows that indeed across all parts of poverty, from less than 50% of the federal poverty level to double the federal poverty level for family income, kids are poorer than any other sector in this country. And compared to our peer nations, our rates of child poverty are appallingly high. There we are between Bulgaria and Chile as the richest country that's ever existed. We're an outlier. There's something different about us. And it's because of things that we've done. And I don't have to tell you, especially knowing the community that this institution has traditionally served within Portland, that the rates of poverty are not equally distributed across the community, and that children from minoritized and marginalized communities bear a much higher burden. Oregon, fortunately, as we like to think we are, is better for kids and poverty than elsewhere. In 2024, around 16 to 70% of kids all told live in poverty in this country. And our rates are a little bit less, although you can see we also have the rates are highest for the youngest kids. What does poverty really mean? And we think we know poor. So in the 1960s, there was a lot of unrest, as you know, civil rights movement and the war on poverty. And the federal government was making movement towards working on addressing some of the structural disparities, including poverty, and realized if we want to talk about poverty, we have to have a common understanding and language around it. And they realized there was no universally applicable definition of poverty. And so they tasked economists within the federal government to come up with that definition. And there was a woman in 1967 who recognized that if you took in 1967 dollars the amount of money it would cost to feed a family of 4 and tripled it, that was the amount of money it would cost to get them from January to February to March. And that's where the federal poverty line came from. And it turns out we use a minimally modified version of that. And this is what it looks like in 2024, that if you were a family of 4 and you earn $31,200 or less, you live in poverty. If you make $33,000, you don't live in poverty, because you need a line. That's the line. What does it cost to get through a month in the Portland metro area? So this is from a group called the Economic Policy Institute. The reference is underneath the thing on the bottom. It's just being hidden. And you can find any community in the United States, and they estimate based on these things. And these, housing, food, childcare, transportation, these are necessities, right? This is subsistence level, what it takes to get from Monday to Tuesday and from January to February. And this is what it costs in Portland Metro to survive. Bottom 2 rungs of Maslow's hierarchy. So if you live at the federal poverty line, if you make a family of 4 that makes $31,200 a month, you are at about a quarter of what it's going to take to make it from Monday to Tuesday and January to February. What's the minimum wage in Oregon? And I know it's sort of not a fair question because it's changed. So I don't expect anybody to know, and I had the advantage of cheating because I could look. We're at $15.95. We are the envy. Like I did this talk a month ago in Minnesota. I've done this talk in a bunch of places where the minimum wage, like North Carolina, is still $7.75, the federal minimum wage. We're at $15.95. Most states would kill to get to $15 an hour. So if you are a minimum wage worker and you work 40 hours a week, 52 weeks a year, no vacation, you will make 26. So you will just be over the federal poverty line. Going back to, we did this, we can fix it. We know we can because we have. In 1959, right before all of the war on poverty and the civil rights movement, 35% of senior citizens, and as I get closer to 65, right, 35% of senior citizens live in poverty. This was the age of grandmas eating cat food. And 27% of kids lived in poverty. And through things like Medicaid and federal nutrition programs like WIC and SNAP and improvements to Medicare and some of the fixing all of the holes in the social safety net through the 60s, poverty for the elderly dropped by about 1/3 and by about half for kids. It's amazing. And then as we went through the 70s, things continued to get better for the elderly, stayed stable for the kids. Through the 80s, got a little bit worse. 90s, and now. So we haven't made all that much progress for kids. We made things better, and then we sort of accepted a status quo until the pandemic. When one simple thing, the child tax credit, as every economist and every smart pediatrician who understands health economics said, something that simple decreased child poverty by 50% in a single year. And then the minute it was gone, child poverty went right back up. We did this, we can fix it. We know how to do it. We just have to have the will. But it costs us. If you get 50 kids in first grade, and sadly, in this country, that might be a single class. My sister, one of my sisters is a special ed elementary teacher. These are her kids. 50 kids show up in first grade, not up to speed on reading. What are we gonna do? We're gonna try and identify them, right? Like pediatricians will screen, we'll find them, and then we're gonna do everything we can to fix them. And by the time those kids, these 50, this cohort of 50 gets to fourth grade, if we've done everything we could and we did everything right, maybe 6 of them will have gotten to level. And the rest of them, never gonna happen. Done, gone. It's like, this is why. We know 95% of brain growth happens in the first 5 years of life, and we know about those first 1,000 days and how crucial that is. Look at where we spend money in blue on kids. We don't start spending money on kids until they get to school, and then we see problems, and we try and rectify it. Right? How many gardeners are here? How many people have tomatoes? Great. This is the equivalent of waiting till this to say, oh, water. Right? This is what we're doing to our kids, and especially to our poor kids and the kids who come from traditionally marginalized and minoritized communities. And that's not okay. And the question I want you to think about as we jump into the next section here, this is the depressing part, it's over. Now we're going to talk about what we do about it. But I want you to think about what you can do to fix these things in your job and how you are valued and what you are valued for, okay? And you care about this because all of us are going to rely, at least to some extent, on Social Security. You remember the first time you ever got a paycheck? You knew exactly what you were making per hour, and you calculated it out because you were smart, and then you looked at the paycheck and you're like, what? Who's this FICA guy? And I remember taking mine like outrage to my parents saying, what the hell is this? And I'm saying, oh, it's okay. This taxes, like this all stuff. And Social Security, this is for when you retire. And I remember feeling some solace that, all right, well, at least they're taking this out, but I'm going to get it back. Well, that's not how Social Security works. When Social Security was established in 1935, it was clearly designed so that current workers would be paying in for each recipient, each retiree. And back then, demographically, the country was different, and there were 5 workers paying in for every retiree. Well, we know that demographics have changed. By the time, if you retired today, there would be 2 people, 2 workers who are currently employed paying your Social Security benefits. By the time we graduate, it might be retire, it might be 1. So if it was 2, and you got a chance to pick those 2, right? Because think about it, as pediatricians and child health professionals, what we're doing is we're kind of preparing them, right, to be our safety net for retirement. Would you want it to be these 2 kids or these 2 kids? Because you got about a 1 in 5 chance it's going to be them. All right. Advocacy, really hard word. And when I say advocacy, if we were to go around and ask everybody for a definition, I would probably get as many different definitions as there are people in this room. It means something different to everybody. So I want to come to some common understanding of what it means so we can have an idea about what we can do. So this is what the dictionary says: the act of pleading for or supporting. I don't know that that really helps us get to what is our role as physician advocates or child health professional advocates. I kind of like this, the idea of being an upholder or defender, because it kind of makes me feel like this, which, make no mistake, we are superheroes. And going back to the Paul Wise statement that pediatricians are the ultimate witnesses to failed social policy, I think advocacy is about us seeing things, right? We see some things, don't we? And being able to do some things to address it. This is the definition that I use, and this is from a paper that was published in 2010, written by an internist and 2 pediatricians at University of Colorado. And they said that physician advocacy, and if you're not a physician, insert your job title here, your professional identity there. I don't mean any disrespect, but it's work that we do to promote social, economic, educational, political change to ameliorate the suffering and threats to health and well-being that we identify through our professional work and expertise. We see stuff. We see some of the worst stuff. We have to be able to do something about it. And I want to be very clear about one thing. The most common response I will get when I ask people to define advocacy is speaking for others. Yes, but we're experts in strep throat. We're not experts in communities. We should not assume we know what the answer to a problem is, or even what the priorities of a community are. And we have a tremendous tendency when we work with communities to go and say, I know what the problem is, right? Obesity, better food, like you change your diet, get more exercise, right? We've definitively proven that that doesn't work. So we have to be very careful and make sure that really what we're focusing on is ensuring that the voice of those who are not heard are heard, whether it's kids, a more specific subset of kids, a community, all of that stuff. And there are multiple different levels to advocacy that we can engage in. We are really good. Pediatricians are the best at the individual level advocacy. That's the stuff we can do in an individual exam room or at a bedside. We can screen for food insecurity. And what happens if a family tells you they're hungry? What do? Great, we have some resources. Here's the number for the food bank. I'm gonna have the social worker come in. We're gonna make sure you're connected to all of the resources that we can connect you to. But if I see that child and family for their 15-month visit and we screen them and they tell me they're hungry and I do that, they're gonna come back hopefully in 3 months for their 18-month well child. We're gonna screen them again. They're gonna tell me they're still hungry. I'm going to be able to do the same thing. How many times can I ask the question? How many times can they see the social worker before something different occurs? So we can engage the community, right? Is part of the problem here that the food resources, that access to food for a family at the end of the month who's hungry from the food bank are not adequate. So we can work with the community and the food bank to ensure that the resources and systems and services actually meet the community's needs. One of my colleagues at OHSU, an infectious disease doc of all people, got really interested in issues of food insecurity in our hospital because she ran into a father on a Sunday afternoon who did not have enough money even to get chips out of the vending machine. And we don't provide food trays for families. And so she worked to establish a food pantry on our inpatient unit. And in the process, went to meet with folks at the Oregon Food Bank. And when she went to the food bank and she introduced herself, they said, oh, you're a pediatrician. Would you be interested in being on our board of directors? And she called me from the parking lot and said, they asked me to be on the board of directors. Can I do that? And my response was, you can't not do that. Like, you have to do that because they need to hear from you because you see some things. So moving out into the community now, instead of hundreds of patients that are flowing through the hospital, she's impacting thousands of patients in our community and across the state. The next level would be addressing why families are hungry in the first place. So this is a map of Portland by food access status, and the ones that are the zip codes that are colored are the food deserts. Green are the deepest food deserts. So really digging in and cooperating with the city council and the county commission and the planning and zoning boards and economic, venture capital, whatever. Why do we have food deserts? Why are families not having access to food? Working at that systems and policy level. Now you leverage the work, so you're impacting tens of thousands or millions of people. And I want to be very clear, I'm not saying we all have to be doing all of this work, but all of this work needs to be done. And my charge to you is to think about where you fit in this, where your passions are, and where you want to be working. Every one of us came to child health because we started with I love kids, right? And we care about kids and the communities in which they grow, because we know that without a strong, supportive, nurturing community, it doesn't work. And we are the experts in child health. Every single one of us graduated from at least 23rd grade, right? And the public knows that. The academy we do nothing if we don't have policy, and our policy begins and ends with the science, which is, if we are superheroes, our shield. People may not like the science, they may try and argue, nitpick around the science, but they can't deny the science. They can try, but they can't. So we can take these two things together, the passion and love that we have for kids and our acknowledged expertise in the science. And these are absolutely essential, but completely insufficient for us to be effective advocates, because most of us don't feel that we have the ability, the agency, and the authority to do that work. And some of it has to do with how our jobs are structured. And I mean, no disrespect to anybody, any of the leadership in this room around that. That's just the system that we've built, right? But we have to figure out how we bridge that so we can actually get into doing the work. So I did not fly here. I live over in the Northwest 23rd area. I drove. So this did not happen to me on this trip, but I swear to God, 3 weeks ago when I went to Minnesota, I sat next to somebody's grandma, as I almost always do. And inevitably during the flight, grandma's gonna ask me what I do for a living. And when I say I'm a pediatrician, what do you think grandma's inevitable response is? Never fails, right? Absolutely, 100% of the time. Why? Why is that the response? I mean, first of all, I don't think I mind it until I really think about why she's saying that. What would she say if I said, oh, I'm a neurosurgeon? Wow, ooh, your mother must be so proud, right? What's the difference? And they're not better than us. They're not more powerful than us. They're not smarter than us. They're just perceived differently. And we've allowed that to happen, I think, to some degree. It's not untrue. We are nice. We know that. I mean, every one of us went into child health because we saw other professionals in this space, and we identified that as the person that we wanted to be, right? I don't want to change that, but I think this is how the world sees us. Some soft focused Norman Rockwell-y thing, right? This is worse than the what is pediatrics slide. The problem is that if we're seen as nice, we lose power. Power without love is reckless and abusive. And we, as pediatricians, through our patients and families, witness what power without love looks like. But love without power is sentimental and anemic. And what grandma is saying with her no is, yeah, I see you as nice, but not strong, not powerful. And we have to fix that. We've allowed that to happen. And the way we do that is we get pissed off or excited about something, right? There's no universe in which I ever planned or expected to be the car seat guy. But I had 5 straight call nights when I was in my first job out of residency where I got called to the emergency department in the middle of the night to take care of a kid who'd been critically injured in a car crash, and none of them were trained. And after the 5th one, I'm like, damn it, somebody has to do something about this. So it starts with passion. Every one of you has something. We go back to our wheelhouse, our strength. What is the science? What does the data show? We become experts in that thing because that is our shield. We're also experts in building relationships. That's what we do every single day in an exam room or at the bedside, right? Relationships with kids, relationships with families, relationships with colleagues. So we take our passion and expertise and the science, and we build relationships, and we can change things. And these three things are absolutely essential, but also completely insufficient, because we tend to lead with numbers. Like, science is about numbers, and we try and convince people with science and data. We know why you should get the measles vaccine, right? Numbers don't change people. Stories change people, right? People will, Maya Angelou said, people will forget what you said, they'll forget what you did, but they'll never forget how you made them feel. The things that our families live through, the things that we see, we can tell stories, and even better, we can help the communities tell their stories, and we can do that. Everybody recognizes this kind of person, right? We've all been there. I want you to think really specifically about your experience in neonatology. I don't know if we have any neonatologists here today, right? They're all up saving lives, which is great. What's the single greatest risk factor for premature delivery in the United States? Poverty. This is the state of Oregon by county by poverty rates. The darker the red, the more impoverished. So red, and then orange, then yellow, then green, then dark green. And the one on the right is Oregon by premature birth rate by county. And if you superimpose them, our state looks like almost every other state. You can tell where I've been in the last 7 months. It's always the same. So think about the neonatologists you know and what they work on, right? Especially in academics. When I was in residency, it was always about ventilators and infection control and all of this stuff about treating preemies when making sure they survive. We know that it gets worse, though, because not only are you more likely to be born premature if you live in a poor county, but if you're born premature in a poor county, you're more likely to die than if you're born in a rich county. And we know that that risk is not equally distributed across the population. I'm sorry, this is Minnesota, not Oregon, but it's no different in Oregon. This is my romantic ideal of the best neonatologist in the world. And the reason this is the best neonatologist in the world is that he's bored and his NICU is empty. And the reason his NICU is empty is because he went out and helped fix poverty in his community, and the preemies stopped coming. Now, I know hospital executives might get a little upset about that, but wouldn't that be amazing if the NICU was empty? Yeah, and the PICUs, and like all of this, that's what we should be doing. So how do we align this work with what's really valued in medicine? What's valued in our institutions? We know, right? Billing and coding, seeing patients turn in rooms, education, and not universally, but certainly in academics, science, scholarship, right? I work at an academic institution. I could stop teaching tomorrow. I could stop doing any scholarship tomorrow. Nobody's going to notice until at least my next annual review. And even then, it's probably unlikely, right? But if my charts from Monday are not done on Monday, I get a nasty gram, right? What we're really valued for is this. And it's because of the way that we have allowed things to be structured. When we think about promotion and tenure, and I recognize this might not be 100% applicable to a community-based children's hospital like this, but the way that we tend to show value in pediatrics, and especially in academics, is through changes in sort of career status and promotion and tenure in academics from assistant professor, associate to full professor, as an example. And we tend to think about that trajectory as a three-legged stool, where there's service, which is primarily clinical service, but it may also be service to the institution or the profession. So you could serve on committees for the hospital. You could have a leadership role in the hospital. Scholarship sort of makes sense on its own, and then education. These three legs of the stool are what we tend to get valued for, and every promotion and tenure system works in some way around those three. So this is my family. So my sister Carrie on the right is the special ed teacher. That's me next to her. My sister Julie was a medical social worker, although she did geriatrics and she burnt out, and now she's not doing that anymore. And then my brother with the epileptic rescue dog Peggy, who sadly is no longer with us. My brother Luke is a pediatric pulmonologist at Seattle Children's. When we moved, my sisters are obviously both adopted. We were the second family in New Jersey history to be allowed to adopt interracially. Julie joined us when she was 5 months old in 1970, and then Carrie came from Korea in 1973. And we moved from New Jersey to a small town in New Mexico in 1974, and they had no idea what to do with us, to the point that the newspaper felt it necessary to warn the public that we had arrived.
Famous.
This is my brother today. That's his lab. This is one of 57 pages of his CV of his publications. So he's an MD PhD. The minute he decided he wanted to become a pediatric pulmonologist, this was the path for him. He knew exactly what to do. Not that it was easy. I don't want to give any illusion that any of this is easy, but everything was there, right? There was support, there was an infrastructure, there were people along the path saying, do you need a cookie? Can I get you some water? Are you doing okay? What's the path if you want to do advocacy, if you want to do community engagement work, or you want to get involved in systems and policy change? Naked and afraid. You can look at my CV and it looks like it makes sense. The same way that people in Naked and Afraid, like they make it from point A to point B, right? But it wasn't a linear path and it was not easy. We need to fix that. What do you do if you want to work in the Obama White House like Shale Wong did? Or you're called to testify because of your expertise before the state Senate? Or the US House of Representatives to talk about guns? Or this is my friend Steve Federico, who is one of the two authors on the paper that defined advocacy, having the courage to go on Fox News and talk about immigration and child health. How do you get valued for doing this work? Because you're doing this work, you're not turning rooms, you're not generating revenue. I had an epiphany. About 5 years ago, my brother and his family came down for Thanksgiving, and we were in the kitchen and we were cooking, and I asked him what he was working on. This is what he works on. He works on GI microbiome stuff for kids with CF. This is what he studies, which, having shared a bedroom with him for 15 years, totally on brand. But he started talking about poop with the same fervor and passion that I talk about car seats with. And it occurred to me, oh, this is your advocacy, right? This is what you're doing to ameliorate the threats to human health and well-being based on what you see. But you don't think of it as advocacy because you get $1 gazillion in NIH grants, right? And this is your scholarship. So you're not thinking about it in the same frame and the right way. You are an advocate, just like everyone in this room is an advocate. It just may not be in the way that you think about it. And I would not think about that three-legged stool, transforming it into a four-legged stool where we all now have to have some advocacy thing that we carve out as separate from the rest of what we do. But that advocacy is really this. It's the seat that holds the legs together. And so you are doing advocacy. You may just not be thinking about it in that way and calling it what it truly is. So prior to being in this crazy position of president of the academy, one of my roles was leader of this group, the Community Pediatrics Training Initiative, which is focused on training residents to be the pediatricians that kids need, to learn the skills that many of us never learned about working with communities and getting involved in systems and policy change, to really train the pediatricians that kids need. And we've focused a lot on how all of these things interface and how we can help people achieve competency and agency in working on all of them. Like I said, we're all good at the individual advocacy. We learn that in our day job, but how can we get people involved in community engagement and then policy change work? And so we've got a bunch of resources and created a bunch of things that we've published, including this, which is something that might be relevant to folks here. The project planning tool, which really is the Swiss Army knife to how do you think through a problem that, when you have that epiphany in the middle of the night or you're standing in the emergency department pissed off, how do you get past, well, I don't know where to start and it's too big a problem and it's not my job, and actually dig into it? Because we get paralyzed by that, how big the problems are and the fact that we're not traditionally valued for it. And what the project planning tool really looks like is 10 steps that walk you through, all right, here's the problem that you see. How do you start to dig into it and get to something that's going to be accomplishable? And we begin by asking who the community is, because if you wanted to do food security work, it's really different if you're thinking about all kids in Portland or one kindergarten class at a specific elementary school, or a community that shares a similar heritage, so a culturally specific community, or poor kids or Black kids or whatever that might be. And once you identify the community, digging into, all right, what do I really want to do with that community? Getting to, here's when I'm done, here's what the world is going to look like. So breaking it down just that simply, digging into what already exists, because I'm a firm believer that somebody way smarter than me has already figured it out. And if they haven't, then it's a really hard problem and we need to work harder on it. So thinking about what already exists in the community and who might be working on it, ultimately ending up with this, which walks you through the steps. And this is the process that I followed back in 1998 when I was becoming a car seat nerd. I just didn't know that it's what I was doing and this didn't exist. And now it does. And I'm happy to share it with anybody and everybody, and to support anybody here in sort of doing that work, because many people never got trained in these skills in residency. I certainly never did. We also know that we can train pediatricians, practicing pediatricians, faculty and community pediatricians to do this work. This is a program, Community Health and Advocacy Scholar Educators, that we piloted 2 years ago at Dornbecker and at Nationwide Children's in Columbus, with cohorts of pediatricians in a year-long learning community, teaching them essentially what we've taught residents for 20 years and getting them involved in doing this work. Monthly sessions with work in between that got to everything from community engagement to actually practicing legislative testimony. So we know how to do this. These are residents at Dornbecker going through that curriculum, getting involved in policy advocacy by practicing the skills. And so I will humbly offer anything that I can do to help support this institution in supporting you to learn these skills and do the work. We also know that it's really important to be able to tell the story in a way that makes sense. My brother's CV tells the story. We don't have anything that can tell the story of advocacy journeys, how you started with one simple thing, working with a classroom, and that blossomed into something that was adopted by the entire school district or something like that. And so we created an advocacy portfolio that allows you places to put where you're doing health systems advocacy, which really is QI work, where you can put media work that you've done, if you've written an op-ed or you've been interviewed by one of the local TV stations, and you can show over time how that, what the not only what the impact is, but what your personal growth has been in that path, in the same way that a traditional academic would be able to do that. So here are examples from my advocacy portfolio that show you state level stuff, including the fact that I've been privileged to be able to draft 4 bills in Oregon that all passed, and the chance to testify at the federal level, and examples of work that I've done in media that sort of tell that story. And the aha moment for me in the creation of this portfolio is not that it's just a summative thing where I could show it to you and you could see, ooh, oh, okay, you've done some work in this, that's great. But it also provides a roadmap for people to say, oh, you can do that, or I should be doing that, and then be able to map that and chart that trajectory. So I want to end with this. I want to think about the role of healthcare in promoting health for communities. We talked about that disconnect between healthcare and health. What is the role of an institution like this, or an institution like OHSU? And I want to be very clear that there is nothing, anything that I'm going to say about legacy, I could say very much the same thing about OHSU, and I will. So every 5 years, sorry, every 3 years, an institution that takes public funds, Medicaid dollars, needs to do a community health needs assessment. You need to go to the community and say, what do you need from us? What are the problems that we need to help you solve? And you actually just completed your needs assessment, and what it showed for 24 to 26 are these 4 priority areas: access to culturally and linguistically responsive care, essential community services and resources, economic opportunity, educational opportunity, and access to culturally specific and healthy foods, a neighborhood for all, which includes physical safety. What of these can you address in the clinic or the exam room? This is what the community needs. What can you do as pediatricians and therapists and psychologists?
Make sure you're using a translator.
Yeah, so there are things that we can do, right? But we're not going to get, physical safety in the community. We can't fix that within the walls of this institution. We can't fix that within the walls at Dornbeck or OHSU. That has to be done in the community with the community. So one other thing is that every year, if you're a nonprofit institution, you have to disclose your income. And this is publicly available, right? And I want to say one thing, just in the spirit of full disclosure, OHSU does not need to do that because OHSU is technically not a nonprofit. They are a public corporation, and they do not have to publish a community health needs assessment and child health, community health improvement plan in the way that you do. And they do not file a 990, so this information is not publicly available at OHSU. It is available at the other 7 places I've been in the last 6 months, and I've done this at every one of them. So what you can see here is that in 2022, there was a tremendous deficit, and we know that, that's no secret. And the net assets were in the negative. In addition to just publishing that information, the amount of money spent on community need, i.e. addressing the community health needs assessment, also needs to be published, and that's through this, which is called Schedule H of that 990. And what you can see is it includes funds that were used to meet Medicaid and Medicare stuff, community health needs, community health improvement services. So this is basically addressing the community health needs assessment, health professions, education, subsidized health services. So that's the free care and all that sort of stuff. This is what Legacy, this is not Randall, this is Legacy, put towards addressing the community health needs assessment in 2022. About 0.3% of total revenue, which, to be honest, is not bad. Looking at other institutions, I mean, we can argue about whether that's enough or not. Compared to peer institutions, it's not that bad. But go back to the community health needs assessment and what they said they needed and wanted. This is what's being spent on that. All right, I will say this freely. It's less than this at OHSU. I guarantee it. We got to work on that. The problem is when we want to work on that, what we hear from the institution, we can't afford to do that. Because if you're doing that work, you're not generating revenue. If you're generating revenue, then yeah. But why did you become a pediatrician? How are you feeling? Because we don't think about this. Like all of the micro and macro aggressions and just the moral injury that we go through every day doing our jobs. My wife, general pediatrician, is in clinic all day today. She will get home at 7:30 tonight if we're lucky. We will have dinner and then she will sit on the couch. Right? You all know that. How long can we do that? How long can we keep pushing the rock up the hill to come back the next day and find out it's in the same damn place like Sisyphus? I would be fine if I push the rock up on Monday and I come back on Tuesday and it's an inch closer. All right, if that's the case, I'll push on Tuesday. And if on Wednesday I come back and it's an inch closer, I can keep going. And for me, that's the vaccine for burnout and the salve for that moral injury that we all feel. It's the work that you signed up to do, that you wrote about. And think about where you are. Like, we're fortunate that we generally, for the most part, don't have to worry about the turtle problems, right? What you wrote on your personal statement is the top of this. And where are you in that? And if you're not where you need to be, how can we help you get there? And I think that engaging in meaningful work, meaning bridging that gap between healthcare and health and actually being able to address the things that we see, the failed social policies that we witness, is what we need. I will end here, and I apologize for going over. Howard Thurman was Dr. King's spiritual advisor, and he said, don't ask what the world needs, ask what makes you come alive and go do it, because what the world needs is more people who've come alive. Our kids and families and communities need us to be alive and thriving. And we've got to figure out ways that we can work within the system to do a better job, to be the effective advocates that kids need. So I will end there. I look forward to questions. Thank you again for this opportunity. And I thank you for sticking with me, even though I ran a little bit long.
Does anybody have questions? Wait, I have this microphone. It's kind of fun. I'll bring it over here.
I cannot tell you how much I enjoyed this talk.
Me too.
I'm an infectious disease hospitalist here, but in my early years, I was a PCP in rural Missouri. Where
You've seen some things.
To go. And I was the only pediatrician doing what you said and what was expected of me. And that was my eye-opening of how much poverty these families had and the children. But my job was to see, treat, next, go to court, defend. And I would have not had, I mean, the day was not long enough for me to carve time out to do advocacy work outside the clinic and the hospital. So how we, as the individual provider who's in that position, can help change the system to give us the breathing room to do that too, which is equally, if not more important.
Right. I think thank you for that. That is exactly the right question, the essential question. And I think we need to be advocating for that it is not enough. What we are valued for is providing widgets of healthcare, and that has not changed the health of children. And we need to do something differently. In the last year, there were 2 policy statements that were published by the Academy. One on a vision for Medicaid that would provide continuous eligibility, universal coverage, and payment parity with adult services, which would be massive. And also, and I think this is the more eye-opening publication for me, was a publication called The Value Proposition of Child Health, and how you cannot, in the same way that kids are not little adults, pediatricians are not little internists, pediatrics is not little internal medicine. And the metrics and systems that have been created, we're trying to stuff pediatrics into it in a way that just doesn't work. And that doing the work of advocacy, the outside upstream work, is where we're actually going to achieve value. And so we've got to work to transform that. The National Academies of Science, Engineering, and Medicine, NASEM, which should be just the National Academy of Medicine, is rolling out a comprehensive report on this on September 15th, I believe. And we're very hopeful. We have not seen it yet. Several of, there are some very prominent pediatricians who have been part of that process, actually been leading that process. We're very hopeful that that's going to provide a roadmap to think about how we actually transform the system and make a strong argument that we have to think about it differently. That pediatrics, from a fiscal standpoint, does not fit into a one-year spreadsheet, and you don't save money by decreasing ER visits and hospitalization like you do in adult medicine. So we have to shift the narrative completely. And I feel like we've got some momentum in doing that. It's going to be a while. In the interim, anything I can do to help support you in thinking about how you do that work, anything I can do to help support all y'all, and not just in the context that we may soon be related, which is great. I'm all about marriage. But kids need it.
Thanks for your time. I'm Eric Seymour. I'm one of the hospitals. Kind of piggybacking on that, I think we know, innately in the work that we do, but also there's a lot of anti-poverty research outside of medicine that shows that kind of upstream interventions that you're talking about have the biggest ROI, which is the language that legislators talk about and they talk in. But how do we convince in kind of the very fee-based service, like boots on the ground, how do we change people's minds in terms of our value inherently is not in the services that I can bill for, but the services that I prevent somebody from needing to bill for in the future. Right.
So right, we've got to transform the system. I think, and it needs to start locally. So thinking about things like, I really do not like the use of value-based when we're thinking about contracts and all that sort of stuff. Because when we say value-based to somebody who's paying, they think they're saving money, right? It's really that the point in pediatrics is not to limit access to care to save money. You actually want to max. It's watering the tomatoes, right? We have to shift that narrative. I think having leadership that is sensitive and responsive to that, and I will be quite frank, at Dornbecker, I have a leader who's willing to do that. I think the leadership of OHSU thinks very differently. You can tell them I said that. There are institutions and places where that is really valued. I think there are ways to tie it into the community health needs assessment, the community benefits work. There are ways to tie it into contracts with payers and to think about how it sits at the state level. And like Medicaid policy is there's a lot of Medicaid policy that's set in the federal government, but most of it is set here. And every one of you has a state rep and a state senator that, unless it's Lisa Reynolds, the pediatrician, doesn't know anything about child health and probably would really benefit from getting to know you, because once they know you, they can't not know you. And you have expertise and you can help advise them. We always think about those relationships being to push an agenda positively, but honestly, some of the greatest impact that relationships between pediatricians and legislators can affect is decreasing levels of resistance. So getting somebody from, I'm going to stand up on the floor and rail on this, to I'm not going to vote for it, but I'm not going to push. And those things can be transformative.
Perfect. Thank you. Do you have your hand up?
Thank you so much. So I think one of the barriers to creating more pediatric advocates is that pediatric training intrinsically takes place at academic institutions, and at least at the academic institutions that I've been at, advocacy isn't valued. We don't see that as valued. People don't get academic promotions for doing advocacy work. And so trainees aren't seeing that. So is that something that is changing, or how do we change that?
Yes, and I took that out. So part of the impetus for the advocacy portfolio. So if you go back 20 years, and I say this is wearing my recovering residency program director hat. Back in the early part of the aughts, nobody got promoted on education. And in 2006, I think, the AAMC published a paper on the need for an educator's portfolio to tell that story. And what happened as a result of that is people were able to tell that story, curate all of their experience, and advocate for promotion and tenure practices to change. And now every department of pediatrics has a vice chair for education, which didn't exist before. And a lot of people get promoted on education. So we just, the principle that somebody way smarter than you has already figured it out, we just borrowed from that playbook with the advocacy portfolio. And I know now of at least a dozen, probably closer to 20 institutions that have changed their promotion and tenure guidelines. And OHSU was one of the leaders. We specifically call out testimony as scholarship. Because if you think about it, if you do research and you write a paper, right, you send it in, you did the work, you send it in, somebody reviews it and judges it for merit. And if it's judged to be meritorious, it gets published and it lives in the public record forever, right? If you, Wendy, if you write testimony about a bill, it will get read. It will live on the public record. If you go to deliver testimony, you might be cross-examined, right? Which is way more stressful than getting a paper back from a reviewer. And it's going to live on the public record. If you get invited, if they say, oh, Dr. Hassan, will you come down and testify on this because you're the expert? You're being identified as the person, which is a lot of what promotion and tenure is about. So us, Duke, Dartmouth, Stanford, I'm blanking on a bunch of the others, have shifted their promotion and tenure guidelines. So now, I mean, I got promoted because of advocacy, not because of publications, because I don't have that many. So shifting that. Residents do, and you became an intensivist because you worked with intensivists and you're like, I want to be them. Like there's that one or two, there's one or two people who like you wanted to be when you grow up. They need to see us doing that work as well, the advocacy work. And if they don't see that, then they won't do it. So we're still in those stages, we're still building that. But I think what you're saying is, I agree with completely, and things we've been working really hard on. I think figuring out how we apply that to an institution like this is something we have not gotten to yet because the focus has been on academics, and I'd love an opportunity to help think about that.